Please welcome Dr. Abonour.
Good morning. Can you hear me okay? Great. So yeah, I have a scooter and my mom lives with me and she has a walker. So we have now traffic lights and, lane. Mom, that's your lane, this is my lane. It's a lot of fun at my house. So we're gonna try to talk about myeloma and how can we get rid of myeloma. I think what we need to do is understand myeloma first to be able to get rid of it. So how do myeloma cells survive? What is the nature of the originating myeloma cells? Understand that not all myeloma cells within each one of us are created equal. They are different. And also respect the immune system of the patient, because I think it's very important in helping us eradicate residual disease. So myeloma is really sort of these evil cells living inside the bone marrow. And what they do is they, try to make a niche for themselves within the bone. So they make holes in the bones. And what they do is they stimulate the cells that destroy bone and inhibit the cells that build bone. And at the end of the day, you get this sort of vicious cycles of cytokines, these hormones that will stimulate myeloma cells to grow. And trying to get rid of just the myeloma cells is not enough. You want to make the stroma, the bone marrow where myeloma cells grow, inhospitable for myeloma cells. And that's why I think some of the novel agents we use have helped patients with myeloma live longer, because we're not just focusing on the myeloma cells, we're focusing on the neighborhood where they live. The other thing is that perhaps the myeloma start from a very stubborn cells, cells that is hard to kill, it's hard to eradicate. We kind of call it myeloma stem cells. And how do we get rid of that myeloma cells? Maybe just using a monoclonal antibody that attack the surface of that cells may play a role in eradicating myeloma. The other thing is that, is these what we call clonal heterogeneity. Not all myeloma cells within the patient behave in the same way. Some myeloma cells will respond very well to drug A, but not to drug B. And so if in the old day we used to say, well, let's sequence, let's use drug A until it doesn't stop working, and then we use a drug B when the patient relapse. Why not use drug A and B together so we can get rid of all the different clones within the patient? That's why combination therapy became very popular in treating myeloma patients. Not one drug, not two drugs, but now 3 drugs and probably very soon 4 drugs to try to achieve the maximum eradication of all these nasty clones within the patients. If you're gonna make progress, you wanna get rid of myeloma. So, and how do you treat elderly patients, yeah? Well, you treat them with respect. This woman is 103 years old, Ida Keelings, and still running and still winning. So, I don't know if she has an Achilles problem, a subtalar joint problem like me from all the running, but she's still going. And I think, to say artificially that age matter, I don't think that's fair. So if it's not the age, what do we pay attention to? We have to pay attention to, other diseases. We have more diabetes, more hypertension, may influence the choice of treatment and how we deliver the treatment safely. Our organs age, my ankle has aged and I had to have surgery on it. So we need to know that our heart and lungs and things like that may not tolerate certain drug well. And then we have the insurance company, we have doctors group, we have governments decide for us what to do and have an artificial line. If you are, younger than, older than 65, you may not get transplant in some part of the world. Those are artificial things. And then we have, our, family, I can't drive myself to the clinic, then I may choose an oral regimen instead of an intravenous regimen. And we're trying to understand how people tolerate the treatment based on something we call the frailty score. So basically, you heard Dr. Palumbo from Italy try to say, okay, if you have these certain things, if you are frail, you're not going to tolerate very aggressive treatment. And if actually, the chances of discontinuing treatment because you are frail is much higher if you are not. For example, if your score is 0, discontinuation of treatment rate was only 17%. But if you're quite frail, that goes up to 25%. And the score is, you see this, it's in your slide. You can use that calculator at the bottom. And it depends on age, on other comorbidity, how is your daily activity, and you can come up with a frailty score that help you choose the right treatment for you. So the goal when we try to treat patients, first of all, when we are treating now symptomatic patients, we're not treating smoldering patients. So we want to eradicate these symptoms. If you're anemic, we want to correct the anemia. If you have kidney damage, we want to improve the kidney functions. We want to preserve your organ because we want to make sure your heart and your lungs and your kidneys are working efficiently and improve your quality of life. So remember, we're not going to be able to reach a room in 1 month, but we need to try to get rid of myeloma as quickly as possible to improve your quality of life. This is the component of treatment. Everybody gets an induction, everybody gets in consolidation, intensification, and maintenance. And then along the way, we have to address supportive care. So what were the drugs? What are the drugs we use for each step? In the old days when, most of us in the room started, we had the VAD, the high-dose dexamethasone, 40 milligrams for 4 days on, 4 days off. We had the stem cell transplant. We had nothing. And you can see now we have tons of drugs for each sort of component of the treatment. And the thing about it is that what we are using in rescue and relapse, no longer using them there. They are moving up front. Because if they are good drugs, why wait until the patient relapse? Because I think after multiple relapses, that's not, it's hard to maintain quality of life. It's hard to control the disease. So let's use these drugs early on. So there are several classes of drugs we use. The proteasome inhibitor, so the first drug in that class was Velcade, then the drug carfilzomib or Kyprolis, and then the oral proteasome inhibitor, Ixazomib or Ninlaro. The immunomodulatory drugs, the first drug in the class was thalidomide, and then came Revlimid and Pomalyst. And then monoclonal antibody, we have 2 of them on the market. One is daratumumab, and the other one is elotuzumab. And I'm not going to talk about everything because it's just a lot of these trials, but they all have role in managing patients, whether they are transplant eligible or ineligible. And the good news is that the initial choice of treatment can be tailored to your medical conditions. So the other thing I want to show you is that getting rid of myeloma is a good thing. If you're going to live a long time, you need to get rid of myeloma. So getting a deep response, first of all, I'm going to show you that when we are using novel therapy today, the patients are living longer. More patients living 5 years, 10 years today because we're using novel therapy and we are achieving more eradication of myeloma. Very good partial response that getting rid of 90% of myeloma. CR getting rid of 100% of myeloma. If you achieve that, you're going to live longer than patients who just get a partial response. We should not be accepting anymore 50% reduction in myeloma. You still have myeloma protein around. You still have myeloma around. You're not going to live as long as the patients who get rid of their myeloma early on. So we need to find a combination therapy that provide you with the deepest possible response. Getting rid of myeloma is a good thing. So how did we get there? How do we do it? First of all, for a long time, we believed that high-dose dexamethasone, the 40 milligrams for 4 days on, 4 days off, 4 days on, 4 days off, staying up all night, then 4 days you are on the couch, 4 days your blood sugar 1,500. We used to love that regimen, but not anymore. Why? Because we did the right clinical trials. How many of you had 40 milligrams of dexamethasone for 4 days? Oh, wow. And how much do you love that? No, I don't think anybody will love that. But so what we did in ECOG, in the Eastern Cooperative Oncology Group, we said, Revlimid is a great drug. Let's see if we still need the high-dose dexamethasone, the 4 days on. Maybe we should just do one dose 1 day a week. And that's, we had a patient who's very active in the International Myeloma Foundation, had myeloma for a long time, Mr. Cat, and he said, I want to try this. So we said, okay, we'll do it. And the goal was to see which arm is better. And what we showed, that actually high-dose dexamethasone can give you better response. You're getting rid of more myeloma, but unfortunately, look at the bottom line here. Early death in the first 4 months, 5% of the patient who get high-dose dexamethasone lost their life, compared to 0.5%. So what we did is that we said, no, I think we should adopt the weekly schedule, and I think by 3 years, 75% of the patients were still alive. So we think that's the standard dose now for dexamethasone once a week, compared to the 4 days on. The other thing is that actually this is a Revlimid, and the dexamethasone was a very good story whether you get transplant or not transplant. You can see with transplant, it's about 92% of the patients are alive at 3 years, compared to 79% in the patient who did not get transplant. But the non-transplant group were 10 years older on average than the transplant group. So I think there is suggestions that you may benefit from good treatment, whether you get transplant or not. So now we said, okay, Revlimid Dex really worked. Can we make it better? So the next step was adding Velcade to it. And already Dr. Dury stole the thunder and told you that he did a great clinical trials in SWOG and showed that RVD should become the standard induction treatment compared to just Revlimid Dex. And I told you earlier that combination therapy is very important. You don't need to wait until you relapse. So what he showed you is that you're getting more responses, more deep responses when you use 3-drug regimen versus 2-drug regimen. And I want to show you here on the bottom, if you are older than 65, you still benefit from 3 drugs regimen compared to 2-drug regimen. We used to say, if you're elderly, we need to treat you gently. We need to use 1 drug and then wait. No, get rid of myeloma, adjust the dose early on, use 3-drug regimen, you're going to improve the outcome. So the theme now is that let's add more drugs to what we think is maybe the standard of care. So the first thing was, in Europe, our colleagues use Velban, melphalan, prednisone. They use, Velcade, melphalan, prednisone. So Velcade injection, melphalan a pill, prednisone a pill, and that their standard induction. And the question, can we improve on that by adding daratumumab? So this is a study was done mostly in Europe. And daratumumab, you're going to see more about it later. It's a monoclonal antibody, bind to the surface of the myeloma cells, destroy the myeloma, bring the immune system, and help get rid of more myeloma that way. So Darzalex or daratumumab. So this is the design of the trial. They get VMP for 9 cycles, and the other group get VMP plus Dara, and the question, and then you get maintenance Dara. So the question is, which group is going to do better? And it looks like by adding daratumumab to the regimen, you're getting it taking you longer to relapse. More patients are staying without progression, without relapse, when they get daratumumab. So again, combination therapy does improve the outcome. And here, this is we call sort of subgroup analysis. I just want to focus on the age, and if you were younger or older than 75, you still benefit from adding daratumumab to the regimen. And I think this regimen is really good because you're getting rid of more myeloma. The depth of the response, getting more VGPR or higher, was better in the Dara arm than just the chemo Velcade arm. And the other thing is that you're hearing about is the minimal residual disease. Being able to get rid of a lot of myeloma. When you go to the bone marrow and try to analyze 1 million cells and you find no myeloma cells in the bone marrow, that's MRD negative at 1 to the -6. If you analyze 100,000, that's to the -5. So when you get MRD negative, when you analyze the bone marrow and you don't see any myeloma, that's a good thing because you enjoy a very long life without progression. And that was achieved more when you add daratumumab than if you just use combination therapy. So now the question is, can we use daratumumab with stuff that we use more commonly in the US. So we told you that Revlimid Dex works, add Velcade to it worked really well. How about Revlimid Dex, let's add daratumumab to it. So this is a study called MAIA. We always have name for these studies. And so in this study, standard Revlimid, standard steroids, one arm, and the other group get daratumumab added. So what do we get from that? What you see here is that it's taking longer for patient to progress, to relapse, when they get daratumumab compared to Revlimid Dex. And so that's a good thing. And so there's 44% reduction in the risk of progression. Again, if you look at the age, actually, it's a good thing. If you're even older, you can still benefit from that combination compared to just Revlimid Dex. And what else? And also the stage matter. Again, why are these patients doing well? Why are they taking them longer to relapse? Because the depth of the response, getting rid of more myeloma, is more frequent in the DARA arm, as you can see, 46% versus 25% or something like that. So it's number one is the depth of the response. And if you start doing MRD analysis, you can see 24% of the patients who get DARA did much better than the Revlimid again. So you're getting rid of more myeloma. So this is what the conclusion is, that 44% of the patients in that trial were older than 75%. They had a poor performance status, and they had 14% had high-risk cytogenetic. There was no new safety consideration, and I think there's improvement in the outcome. So I think this is a very good sort of time for myeloma patients because we can use more combination therapy. So what do we do when patients relapse? Options at relapse are many. I mean, you're going to hear more from Dr. Richardson later, but there are a lot of drugs, a lot of combinations. I just want to focus on one study that I think is very important for elderly patients, and perhaps this will become sort of the new standard. So Exazimab, or Ninlaro, it's a proteasome inhibitor that is an oral medication, and you can do that, take it once a week for 3 weeks a month. And the question is that if you add Ninlaro or Exazimab to Revlimid Dex, is it better than Revlimid Dex? Yeah? So when the patient relapses, we put them on Revlimid Dex. Can we improve on that by adding Exazimab or Ninlaro? So this is a study that, again, have a fancy name. And what you can see is that the response is slightly better, but the depth of the response was better. VGPR was 48 versus 39%. And you can see there was no significant difference in the side effect of the two regimens. And in terms of benefit, there are patients taking them longer to relapse, to progress, when they get Exazimab, Ninlaro, and Revlimid versus Revlimid. So I think it's a very good regimen, and I think for some elderly patients, maybe this drug will move up front. Why should we wait until relapse to use Exazimab? And I actually have used it in some of my patients who did not tolerate Revlimid before and did after the first cycle, so I just used Exazimab, and they did well. So I think, my conclusion here, and I'm finishing with 2 minutes to go, is that the majority of myeloma patients are elderly. Personalized care should be offered, addressing patient desires, addressing patients' social and medical conditions. We are treating individual. We are treating John, and we're treating Mary. We're not treating a myeloma patient. So every patient have a unique situations, have unique disease, and we should be able to do that. We treat them as a unique individual. I think ongoing assessment of side effects, and the status of myeloma should be the hallmark of therapy. I cannot tell you how many times I see patients come for a second opinion that they have not checked their myeloma studies in like 3 months. And you're still giving them drugs that cost $200,000 a month. Why are you giving drugs and not checking what the myeloma is doing? You need to monitor the myeloma on a regular basis, every month. Is the myeloma doing better? Is the myeloma going away? Is the myeloma progressing? And also you need to address the side effect. Is the patient having fatigue, neuropathy, diarrhea, constipation, not sleeping well? All these things need to be addressed on an ongoing basis. And I think the other thing is that what we need to do is we need to start doing the appropriate clinical trials for the quote-unquote elderly patients. You know, most of the trials are happening is that we take everybody and, you know, older, younger, and then we do subset analysis. I mean, those statistically can be significant, but I would love to see a clinical trial addressing just elderly. So I think, you know, I agree with Brian. I think, you know, we are afraid when we get diagnosed with myeloma, but I think the longer we sort of deal with it, the more hope we have. And I used to, you know, the first thing I say to my patient when I see them is myeloma is no longer a death sentence. You're going to live with myeloma and die from something else because we have amazing drugs. And thank you.
So thank you so much, Rafat, especially for your final comments. Very good overview of the options for frontline and early relapse. So we have plenty of time for questions.
Okay. Questions?
Yeah.
Regarding your last comment, do you consider, what is your brackets for elderly in terms of age, and do you consider fitness in part of that age range?
Okay.
Yeah, I actually stopped looking at the age, you know, because I'm not sure that's meaningful. I mean, I think fitness is very important. Comorbidity, you know, other diseases that they have are very important. You know, when I transplanted a patient who was 80 years old, but she was, you know, she missed only 2 days of swimming. One was Christmas, and I think the other one was Easter or something, you know, because she couldn't go. But so fitness is very important. I think, you know, and we will talk about it later. Organ, you know, function is very important, and you know, but the age itself, I'm not sure how important that is.
I think that the
Yes.
age cutoff is changing with the age of the doctor.
Yes. Right.
So don't invite young doctors.
That's right. No more young doctors. No. Yeah, but I think that really, when we divide up the options for treatment, I think that we should forget about the age and just say, okay, if there has been a decision to have no transplant, what kind of treatments could you use? Or if there's been a decision to use transplant, how does that affect the treatment plan? But really not consider age as the central factor. All right, so please go ahead.
Yeah, okay, so I'm 75 and I'm a new patient, and I've been treated with an RVD regimen, and according to my oncologist, I'm in remission. But yet I'm still experiencing a lot of the fatigue and that was associated with my original reason to be diagnosed with. And at this point, I'm not, and also because of the neuropathy associated with the treatment, that I'm not taking anything, okay, at this point. But what I'm wondering about is whether the fact that I'm still experiencing fatigue, whether the instruments that are being used or tests that are being used to measure my so-called remission are sensitive enough, and maybe I haven't gotten rid of all those,
All right.
those levels of.
So a good point.
That's really good. So fatigue is one of the most difficult symptoms for a physician to really assess, and we have to believe you. We have to make sure that you communicate that with us. We have to study the patient very well. So first of all, were you fatigued when you were diagnosed with myeloma because you had anemia? And what happened to your hemoglobin? Is it better? If it's not getting better, there's something wrong. Maybe you have iron deficiency, maybe you have B12 deficiency, maybe you have low thyroid functions, maybe you have low testosterone. So we need to assess if the hemoglobin is not getting better, because it's so amazing. When you see the myeloma protein coming down, the hemoglobin goes up. I always show my patients that graph on, when they come to the clinic. So and then when the hemoglobin start coming down, you can see the myeloma going up. So if you're still anemic, there's reason for that. We need to address that. So that's one thing. So the other thing is that the drugs, some drugs can have side effects that include fatigue. So we need to adjust the dose of these drugs. The other thing is that, are you sleeping well? Do you have good sleep hygiene? We need to address that. We need to address your nutritions. And then the other thing is that, are you able to walk? Are you doing some exercise? Everybody needs to get about 20 minutes of walking every day. Are you able to do that? And if you're not doing it, why? So there's a lot of assessment that need to take place, not just looking at the myeloma protein. We need to talk to you, look at you, address what's going on. You know, sometimes some drugs cause low phosphorus. You know, some doctors never check that. Low magnesium, some doctors never check that. So you are a whole body with a lot of different things. It's the most complicated engine that we have, you know, around, and we need to address everything, you know, in details. Yeah?
Okay, very good.
I was just wondering, what's the relationship between myeloma and amyloidosis?
Okay.
And what the risk of a patient developing that, and is the treatment the same if they do develop amyloidosis?
Okay, so
Sure. So you saw the immunoglobulin, and you know if it's has two chains. One is heavy and one is light. And the light chains, we have two kinds, one kappa and one lambda. And so what sometimes happens is that you produce an excessive amount of one of those light chains, either kappa or lambda, mostly lambda in amyloidosis. But that light chain can become sort of sticky, polarized, and deposit in tissue and cause tissue damage. So if it deposit in the kidneys, you start leaking protein. If it deposit in the heart, you start having sort of congestive heart failure symptoms. If it deposit in the nerve, you can get carpal tunnel syndrome, or you get lightheaded, and things like that. And so some people diagnose with amyloid but no myeloma. Some people diagnose kind of with both of them because they have tons of myeloma cells in the bone marrow. And some people have been diagnosed with either myeloma or smoldering myeloma, been followed for a long time, and then they develop amyloidosis. So it's very important for the physician to pay attention to the patients, you know, and ask always about symptoms and monitor. So for example, if I'm looking at my patient chemistry, and all of a sudden they had a normal albumin, and the albumin now is 3. Why is it low? You're losing protein. So I would do 24-hour urine collections to find how much protein you're losing. That will raise a flag for me that you may have, you know, amyloidosis. So the problem with amyloid is that detection, thinking about it, a lot of people don't think about it. If you think about amyloidosis and you treat it early on, guess what? You actually do better than, you know, most myeloma patients, because you don't have large volume disease. You get rid of those bad cells quickly, and the patient in, you know, 6 months, 12 months, their organ heals and they feel good. So it's very important that we pay attention to amyloidosis. We try to educate physician oncologists about amyloidosis, because if you don't discover it early and all of a sudden the patient have significant organ damage, that's hard. And the more organs are damaged, the harder to get rid of, you know, to improve the quality of life.
right.
The drug for amyloidosis is different.
No, it's yeah,
Same
very similar.
drugs.
We treat basically a very similar way. And what Dr. Abonour is saying is that, in fact, if you diagnose early and properly, the outcome can be even better. You can have long and sustained remissions. If it's treated later and you have heart damage and kidney damage, then that can be problematic.
And
The main
especially
thing-
for bone marrow transplantation.
Yes,
If
absolutely.
you have amyloid in the heart, it's not good to perform autologous transplantation. Otherwise, the treatment are the same, but
Yes.
the indication of transplantation depends on the presence of amyloidosis in different organs, including the heart.
Right. Assuming the doctor has done their job and has done the testing to discover amyloid or not, in general, if there's amyloid, this would occur at the beginning. In other words, most people who have amyloid have had amyloid at the beginning. In my experience, at least, it's unusual for someone to go along with myeloma and then later they get amyloid, right?
Yeah, Except I do have experience with smoldering.
Yeah.
And, been smoldering for 10 years and then
That
they developed
they can,
amyloid,
smoldering can,
And
smoldering
the light
patients,
chain was elevated,
Right.
for a long time.
smoldering patients can develop amyloid, they can develop lymphomas, so that there are actually a number of options that could occur for patients who are smoldering, not just myeloma. Okay.
Okay, thank you.
You've put an emphasis on treating the melanoma as, what about in a setting where you're on maintenance? You've had 8 years with nothing, and then you've been on the 3-drug RVD, and now you're on maintenance. So your counts are good. When do you add something like DARA, which is what the doctor said down the road he would recommend? But right now your spike is 0.3, and it's been that way for 5 or 6 months. Everything else seems to be all right. We don't know when to sort of question whether we should start with
Right.
DARA or not.
So good question. If you're going along on maintenance with a spike of 0.3, should you accept that, or should you be
Yeah, I mean, you've been doing that forever. You've been monoclonal gammopathy for 8 years. You're doing great. Numbers don't matter. I mean, I guess there are criteria for what we call biochemical relapse. There's criteria for symptomatic relapse. So if you have, an increase by more than 25% of your baseline, we call that biochemical relapse. But does that matter? I mean, I think as long as my patient's M protein is hovering around 0.3, this is great. I mean, I would be happy if most patients behave that way. So I would not add anything right now at all.
No, I fully agree. I mean, if it's not broken, don't fix it.
Okay, Michael?
I'm going back to the previous question. Amyloidosis, how is it noticed or detected, and what is it?
Okay, so
Right, yeah.
amyloid is a disease that basically these abnormal plasma cells making a very sticky protein called amyloid. It's like wax, and deposit in tissues in the body and cause these tissues not to work well. So, for example, if it goes to the kidneys, your kidneys will become leaks normal protein. So the first thing you notice is that your albumin, your serum albumin, start going down. Most people in this room, when they don't have any problem, they're not on big dose steroids, they're not newly diagnosed, their albumin should be normal, 4 grams. If it starts drifting down below 3, you need to start thinking about that. So that's one thing. The other thing is that it can deposit in the heart, usually between the right and the left side of the heart, and it causes it not to function well. So people start having symptoms of congestive heart failure. They cannot walk, a block. They cannot go upstairs. The other thing is that it can deposit in the intestine, and patient may have diarrhea related to that. It can deposit in the nervous system. So sometimes it deposit, if you all of a sudden, you never had a problem and you have now carpal tunnel syndrome. Why? Why your carpal tunnel, having that syndrome? Sometimes it causes numbness, tingling, and sometimes it affects what we call autonomic nervous system. So every time you get up, you're lightheaded, you're gonna pass out. So those things need to be addressed and paid attention to. So that's what amyloid is. It's just extra protein that is very sticky, make normal organs work poorly. Kidneys, lungs, rarely, heart, nervous system, intestine.
The
Right.
diagnosis needs biopsy.
Yep.
Yes.
You need biopsy to prove the amyloidosis, or at least
Correct.
punction of the fat, which is another possibility. But you need to see
Yeah.
the deposit in the organ.
Most of these are very specific things which raise a red flag in the doctor if they're a myeloma expert. Now, for a local doctor, they might not be picking up on that. But if you are seen by a myeloma expert, these are ringing bells in our heads right away. We know that something different like amyloid is going on. Yeah.
I've reached the stage where I am ready to go on to, I'm in my 70s, they don't want to do a stem cell transplant at
Okay.
this point. I'm going to maintenance. I know you can't give me a definitive answer, but how long on maintenance can you go before you start to relapse?
Pretty open-ended. Right in the room here, you have patients who've been on maintenance for around 10 years. So let's just see in the room here. How many patients here have been on maintenance for over 5 years? Okay, yes. 10 years? Yeah, you got a few people here on maintenance for 10 years. There are some longer-term side effects that you can get with Revlimid over the years, but it's safe to stay on it in the long term for a very long period of time with appropriate dose adjustment. Okay?
That I understand. Okay, thank you.
Yep.
Is myeloma a type of leukemia, and whether it is or not, is there a relationship between myeloma and other leukemias?
Okay, this is the interesting point, which I'm going to talk about later, is that we've been realizing that myeloma may be more closely related to leukemia than we've been thinking. I've mentioned a couple of times that when myeloma is active, the myeloma cells pop into the bloodstream, kind of like a leukemia. And so we're even thinking now that that's how you get the lesions. Myeloma is multiple myeloma. So how does myeloma become multiple? It's because those cells pop into the blood and then they go and then they look for spots where they can like seed or settle down. And so there is an idea that myeloma is a little bit more like a leukemia than we have realized, and that traveling through the bloodstream is part of the disease. And now we have the ability to measure those myeloma cells in the blood at very, very sensitive and low levels, and will become a way to monitor the disease, probably. Yeah. Now, there is also plasma cell leukemia, which is, leukemia.
Can just say that initially I was a leukemia doctor.
Okay.
So in the 80s, I treated mostly leukemia with high-dose chemotherapy. And my interest in multiple myeloma started when we began to demonstrate that high-dose therapy could be active as well in multiple myeloma. Just
out of interest,
a small
yes.
example.
Yes, yes.
Okay, we have time for one more question. Michael?
So the latest price I have seen on Revlimid is $760 a pill. Dr. Dury, you said you went 3 weeks as opposed to 4 weeks.
Right.
And that's about $64,000 a year. My question is, as we look forward in trials and research, is cost effectiveness a major concern for us? Or is it, let's just watch it, or let's cure the patient and not worry about the cost?
So this is a really, really important point. I mean, in the first instance, we should look for the best treatments no matter the cost, obviously. I think we'd all agree with that. If the cure for myeloma cost $100,000 or $1 million, I mean, we would be all for it. The main aspect of that is that you would be done with it, right? You wouldn't be paying, $50,000, $100,000, or $200,000 a year. The ongoing costs, however, we can't ignore. And I don't know what comments you'd like to make about costs.
Cost is incredible. And, I just saw an article this morning about how many people went bankrupt because of medical care. It's just not fair. I actually jumped on a clinical trials, and the first patient in the country to go on that clinical trials was my patients on the ASCENT trial.
Yes.
And the reason I like the ASCENT trial, which is treatment of high-risk smoldering myeloma. So this is a clinical trials trying to treat high-risk smoldering myeloma. And actually, the reason I jumped on that trial, because it was an open-ended trial. It's an induction, consolidation, and a maintenance, and the treatment is for 2 years.
Yep.
That's why I jumped on it. Because I know that when I exactly promise my patient that you're going to get a treatment for 2 years, I will fulfill that promise with the goal is to try to cure them. So that's what should the goal of clinical trials is that get rid of myeloma and keep it gone. And I think at the end of the day, everybody will figure out how much money they're going to make, how much money it's going to cost. The insurance company will know when I have a myeloma patient, I'm going to treat them for 2 years. This is how much it's going to cost me. If I'm a drug company and I have a myeloma patient who's going to be treated for 2 years, I'm going to exactly know how much I'm going to charge to make money to satisfy the Wall Street and my retirement and your retirement. So it is important that we know exactly the cost of the care for how long and for how much, but to keep going without knowing when you're gonna stop, you're not gonna be able to manage that. How do you figure out the cost of care if you just keep doing it forever?
Right, right. And there's some new models of how drug pricing should happen. One of them, which is quite interesting, is called the Netflix model. So, which is quite interesting. So, Netflix, when you have a movie, there's a cost to make the movie, right? So ultimately, though, that cost is not passed on. When you get Netflix, you're not paying, millions of dollars. That cost was paid up front, right? So you need to separate out what was the cost of making the movie or making the drug, and what is the appropriate money that should be paid later for people to use the drug or see the movie. And so those two things should be separate. And so we absolutely can't forget about the development cost, but later on, what really is the cost for that ongoing use?
Just an additional word. I have to say that in the United States, patients have more possibilities than in every other country. You have access to all new drugs. Sometimes it's very expensive, but majority of patients have access to all new drugs. It's not the case in other countries, even in rather rich country like France, my country. Imagine that Kyprolis and Inlaro were reimbursed only last year because the government tried to delay the reimbursement because of the high prices. And we still have no access to daratumumab. And there are countries in which they don't even have access to Revlimid. So it's a crucial question, but in my opinion, it's a very difficult question. But what is important is to have a good assessment of the interest of the drug. You have very expensive drugs, including in multiple myeloma, which are not so attractive. I wouldn't say which one.
Right.
But you have many drugs which are really breakthrough.
Right.
And they are expensive, but they improve the results and the quality of life in a manner that the price is justified. So the very important point is that to have a good assessment of what you call the cost effectiveness of the drug. It may be very expensive, but it may be very active. That is very important.
Right. So a key point that Jean-Luc is making is tremendously important in that in the United States, although the costs are high, there is access. For about 80% of the patients with myeloma around the world, there is not access. And in some places, there's extremely limited access. And so the main reason for that is related to the high costs which are established in the US. So that we have the high costs which are established here, those high costs make the drugs unaffordable outside of the US. And so that's why the healthcare authority in France, they say, no, we can't afford this for patients in France. Or you can imagine in Hungary or Czechoslovakia or Thailand or wherever. I mean, it's just a non-starter. They can't get these drugs. And so solving the problem of costs in the US is important for all of us here. But we should not forget about the impact that it has globally in terms of access, which is really so poor. All right, well, with that, I think we're going to have to stop and get some coffee or maybe some vodka. I don't know. Thank you.
Yep.